Today, we will talk about increased intracranial pressure and its management. My name is Alyssa Stoner. I'm a second-year critical care fellow at Children's Mercy Hospital. So first I'm going to start with our objectives, but I wanted to lead in with a case. So you're presented with a 6-year-old male who is status post motor vehicle versus pedestrian accident. He is immediately post-operative in the PICU after decompressive craniectomy and ICP monitor placement. The nurse calls due to his episodic increase of his ICP to the mid-30s with a MAP of 40. How do you approach this patient? So what we need to know is the problem. So really the problem is his increased intracranial pressure. But is this because he's agitated or waking up from anesthesia? Is he in pain? Could he be having seizures? And all of your treatment options are going to depend on his underlying etiology. So if he's waking up from anesthesia and agitated, you could try some sedation. If you think he's pain, you could try some pain control with fentanyl or morphine. If you think he's having seizure, you could treat him with a benzodiazepine and consider prolonged EEG. But why must you treat? So this lecture will help you have a better understanding of why it's important to treat these patients as quickly as possible. So the solution, and I've defined these as our objectives for today. So in order to understand why we're treating these patients, we have to understand the normal physiology and then move into pathology of cerebral blood flow regulation. So we will discuss the 3 components of the Monroe-Kelly doctrine. I would like it if you were able to draw a schematic of the cerebral autoregulation of blood flow, and then recall normal intracranial pressure of the pediatric patient. I also would like you to be able to apply the cerebral perfusion pressure equation to determine the patient's cerebral perfusion pressure. In addition, I would like you to be able to compare and contrast the 3 types of cerebral edema, and then correctly describe the components of Cushing's triad. And last but not least, it's important to understand the management strategies and be able to describe at least 5 out of the 6 strategies that we utilize to minimize cerebral metabolic demand. So let's move into cerebral physiology. First, we'll start with the Monroe-Kelly doctrine. This describes that the skull is a fixed, rigid structure and that there is no room for expansion of any of its contents. Its contents include the brain parenchyma itself, intravascular blood, and cerebral spinal fluid. The brain makes up 80% of the space, when the intravascular blood makes up about 10% and the cerebral spinal fluid makes up about 10%. Ultimately, if there's an increase in one of these structures, the other 2 structures will suffer or be compressed. Here's a pictorial documentation of that. As you can see in panel A, we have normal physiology with the brain volume, the arterial and venous volume with the CSF. As you put in an intracranial mass and compress this area, some of these spaces decrease. And as this mass gets bigger and bigger, you can see that the CSF is being pushed and pushed out of the space of the brain, and eventually you can cause impingement of the brain parenchyma. Next, we need to understand cerebral autoregulation. So this maintains cerebral blood flow. Ultimately, our brain is really smart and it's able to adjust this cerebral venous return to augment the blood flow. In adults, it's typically maintained from a plateau of 50 to 160 millimeters of mercury. However, in children, there's limited data for the extreme ranges. Outside of this range, the mechanism breaks down and you can have hypo or hyperperfusion of the brain parenchyma. And in chronic hypertension, this curve can actually be shifted to the right, resulting in significant consequences if you were to over-aggressively manage their hypertension and get their blood pressure down into a quote-unquote normal blood pressure for age. However, because this patient has been hypertensive for such a long period of time, their brain is used to receiving that pressure and has adjusted the plateau. So if you aggressively treat the hypertension, you're putting the area of the brain at risk for ischemia and lack of blood flow. This is just a pictorial explanation of what we just talked about. This cerebral autoregulation is impaired by disease processes and endothelial dysfunctions such as multi-organ dysfunction as well as sepsis, and it can be heterogeneous in dysfunction. So you can have areas of the brain that it's still intact and then areas in the brain that it's not intact. But as you can see here, you have cerebral blood flow that increases. It will plateau when it's happy between that normal physiologic range of the 50 to 160. And as you get greater than 160, you can see again your blood flow is going to increase. And as you have increased blood flow, you're going to have increased risks for cerebral edema. And then the purple line is going to highlight what happens when the patient is chronically hypertensive and shifting that curve to the right. Next, we move on to this concept of cerebral perfusion pressure. So this is the gradient driving the cerebral blood flow. So you need to have some sort of gradient in order to get blood to your brain. So what are the components of that? So first you have to understand what the normal intracranial pressure is, and this is basically the pressure of the CSF inside the ventricles, and this is determined by both cerebral blood flow and CSF circulation. Normal values are anywhere from 7 to 20 centimeters of water. If you are greater than 20 for more than 5 minutes, you are severely increasing your risk for further cerebral edema. This could result in herniation syndromes, ischemic injuries, or death, and therefore there is recommended to aggressively treat this. So what's the equation? So the equation is your mean arterial pressure minus your intracranial pressure. So your CPP equals your MAP minus your ICP. Normal CPP goals, so in patients who are greater than 18 years of age, a goal is between 50 and 70. In children who are between the ages of 6 and 17, the goal is greater than 50, and in newborns, the goal is greater than 40. So let's return to our case and get a better understanding. So again, I'll just highlight here, this is a kid who has a significant brain injury. He's already gone to the OR, he's had the decompressive craniotomy, and he's got an ICP monitor in placement. The nurse is able to monitor minute by minute what his ICP is doing, and she calls you as soon as he's having periods where his ICP is in the 30s. His MAP is only 40, which is less than optimal in this situation. So how are you going to approach this patient? So first you want to understand, okay, what is his CPP? Is it adequate? And do we need to do anything about it? So in this instance, if his ICP is 30 and his MAP is 40, that gives you a gradient of 10 to suggest that he is not getting adequate blood flow to his brain during these periods. And so I would say in this situation, yes, it's going to require treatment. And what approach are you going to take? So what do you think is happening? Is it sustained and lasting for a really long time? Do we need to treat him for seizures? Do we need to treat his pain and his anxiety? So the nice thing is that benzodiazepines are going to treat seizure and agitation, so you can certainly start with that. You can treat him with pain control with fentanyl or morphine or Dilaudid. And then the last thing you want to really consider is doing this prolonged video EEG. More and more, they're showing that many of these patients with severe brain injuries have actually had subclinical status. So at least identifying and know that it's going on is probably important. And what we're trying to figure out now is what should we be doing about that? And that's a whole nother topic for discussion. So we'll focus on the acute management for this patient. So now that we have a better understanding of cerebral physiology, let's talk a little bit about pathology. So the first thing I want to touch on is cerebral edema. There are 3 types of cerebral edema. So there's cytotoxic or cellular, vasogenic, and interstitial. This chart provides a nice overview of the 3 different types. So in vasogenic edema, this is often seen in patients who have tumors or abscesses, infarctions, hemorrhage, lead encephalopathy, or ischemia. And essentially what happens is you're having increased capillary permeability, so that capillary leak. So you have plasma that is getting outside of the capillaries and is now going into the white matter. And so the edema fluid is actual plasma filtrate. And in this instance, your extracellular fluid is what's increased. In the cytotoxic type or cellular, you're affecting your gray and white matter, and this is in instances when they have hypoxic injury, they have ischemia or meningitis. The edema fluid is actually intracellular H2O and sodium, and so your brain cell is actually getting bigger and bigger and bigger. And in this instance, your extra fluid volume is decreased. The last but also important piece is the hydrocephalus. So this is actually an increase in your intraventricular fluid, and the fluid is actually your CSF. And in this instance, it's often in communicating or non-communicating hydrocephalus, and we can talk about some causes of that in a little bit. As I mentioned, we would discuss some differential diagnosis or why you may have cerebral edema. So I like to break it up into 3 different sections. So space-occupying lesions is where I'll begin. So most often when I hear space-occupying lesion, I think of a tumor. But space-occupying lesion can also be bleeding. If you've ever seen a big subdural hematoma where it's causing midline shift, that's a space-occupying lesion. You can also have this happen with an abscess. Next, we move into more of this diffuse cerebral edema. So oftentimes this occurs after trauma and many times results in diffuse axonal injury. And we could spend a whole lecture talking about that in itself. That is not what this is meant to do. It can also happen in infections, so meningitis, encephalitis, and metabolic causes, so the hepatic encephalopathy, Reye syndrome, DKA, or dialysis with electrolyte shifts. And then miscellaneous, certainly in hypoxic ischemic injury, you could develop significant diffuse cerebral edema. Other examples of this include lead encephalopathy and uncompensated hypercarbia. And then last but not least is this hydrocephalus section. So oftentimes when I think about hydrocephalus, I think about either a tumor that's not allowing the normal flow of CSF, or I think of something that's structural, so you have aqueductal stenosis or you have a hindbrain formation. But trauma resulting in bleeds and infections can also cause hydrocephalus. So I just wanted to touch a little bit about what happens to the brain parenchyma in response to trauma. So when you have a traumatic injury, there's a multitude of things that happen in the brain parenchyma that put it at significant risk for further cerebral edema. So one of those things is the loss of cerebral autoregulation. Then in addition, you get cerebral hyperemia, so you get increased blood flow to your brain, which actually results in increased CSF production. So now we have increasing blood into an area that's a closed space. You have increasing CSF that's also in a closed space, and potentially your cells in the parenchyma tissue are getting bigger all at the same time. And lastly, you can also have vasospasm. And vasospasm can happen like in segments of the brain, resulting in regional ischemic injury. In addition to this, you can also develop obstruction of your CSF, and this could just be due to brain swelling alone, or as I mentioned, cerebral hematomas that cause significant midline shifts. And the combination of these changes results in the brain's inability to compensate very quickly, and this can result in herniation syndromes and ischemia. Most often, this is going to occur in the first 48 hours after injury, but it can peak as late as day 5. So you need to kind of keep that in the back of your head. And as you continue to learn about brain injury, you'll have a better understanding of kind of how we manage these patients and why we're really aggressive at the beginning. And then as the days continue, we slowly peel away our treatment strategies. I just wanted to include a pictorial example of this. So this is just an example of some of the different types of herniation. So here you can see we have a space-occupying lesion in the brain. It's causing midline shift. You can see some stenosis here, and you can see downward herniation or central herniation pushing on the brainstem. You also can see uncal herniation in this picture as well. There are several types of herniation that do have specific names, so I encourage you to go and read about that. So next we're going to talk a little bit about clinical presentation, then we'll move on to diagnosis and how you're going to manage this. So for a patient who is alert and up talking to you as they have increased intracranial pressure, they're going to get headache and vomiting. And we are trained in medical school that one of the first signs that you're going to see is papilledema. And so it's so important that you learn how to do that optic nerve exam. But in all reality, an optic nerve exam is very difficult. And so I encourage you, as you continue your training, anytime you get the opportunity to see papilledema, to take that opportunity and look for it. In addition to this, the patient could also have altered mental status. They're going to have vital sign changes, and vital sign changes are very late in the clinical presentation, so this is going to include hypertension, and that can be associated with bradycardia or tachycardia. As the herniation progresses or you have more severe swelling, the patient can certainly develop Cushing's triad, and that includes hypertension, bradycardia, and altered respirations. If you have that occur, that is something that needs to be immediately addressed. In addition to this, during herniation syndromes in particular, you can certainly have pupillary changes, and this is going to include anisocoria, which, if you recall, is going to be different shapes of the pupils. Your pupils can become non-reactive, and they can be fixed and pinpoint, or they could be fixed and dilated. It depends on the level of brain injury. One of the things that I've heard before in reference to the pupillary changes is, if you remember, pinpoint pons is going to help you clue in that if your patient has pinpoint pupils and they are at risk for significant cerebral edema and herniation, that they may have injury to the level of their pons in their brainstem at that point in time. So how do we diagnose this? How do we diagnose that your patient has increased intracranial pressure? So our patient, very conveniently, had an ICP monitor. So you can do direct measurement, either with the ICP monitor or an EVD, and I have some pictures to show you. And then if your patient does not have that, then they need to urgently go down for a head CT. And some things that you're going to see on that head CT, if they do have significant cerebral edema, is going to be possibly midline shift, basilar cistern effacement. You can have loss of gray-white matter differentiation and effacement of the sulci. So I do have a picture of this to help us further understand. So this is clearly an abnormal head CT. The top arrow is pointing at areas of likely hemorrhage or space-occupying lesions. Here is pointing to the effacement of the basilar cisterns. So that is kind of around your midbrain. And then back here, you're going to see effacement of the sulci. And you can also tell that there's significant gray-white matter, loss of gray-white matter differentiation. And then this is a picture demonstrating the different locations for monitoring intracranial pressure. And so you can have a ventriculostomy. So that's our EVD. So that is actually in the ventricle. It provides an opportunity to actually drain CSF. But it cannot be monitored continually. It can only be monitored as spot checks. And then there's the intraparenchymal fiber optic catheter. So this is when one of the neurosurgeons comes to the bedside and places a bolt. And this is actually in the brain parenchyma. And this can be monitored continuously. And actually, on our monitors and the kids who have these, they will have the ability to calculate the cerebral perfusion pressure and display that on the monitor. You can also have epidural and subdural catheters as well as bolts, but we often don't use those. So let's talk about acute management. So first you have to understand what your goals are. So one, we want to have an ICP that is certainly less than 20, and then oftentimes is advocated in children for an ICP less than 15. And in an adult patient, having a CPP of 50 to 70 is appropriate, but as we talked about before, that it's going to be dependent upon their age. So if this patient is 6, his CPP probably should be 40 to 50 and not in that 50 to 70 range. And then last but not least, the most important and thing that you as an individual can impact is decreasing the cerebral metabolism. So how do we do that? So decreasing cerebral metabolism, decreasing what the brain activity is doing. So sedation by far is going to be helpful. So benzodiazepines are going to be helpful in this situation. Managing temperature. So when the body is hyperthermic, you're going to have increased cerebral metabolism. And so you want to make sure that they do not get a fever. So you can use antipyretics and you can use cooling blankets. FAPCA was the trial that looked at cooling patients in a status post-arrest situation that kind of demonstrated that there was no effect to actively cooling these patients. And so often now we aggressively manage fever control. In the acute setting, the two things that you're going to be able to quickly do is hyperosmolar therapy and managing their CO2. So hyperosmolar therapy, you can utilize either 3% or mannitol, and they have a little bit different mechanisms of action, but the idea is generally to get the free water out of the brain so there's more room for the brain to swell. In patients who are in the acute setting and kind of early on, we like to manage their sodiums in that greater than 140, closer to 145 range. And as they have more significant swelling, and that sodium can be driven up to have more of an osmotic diuresis effect. As far as the CO2 goes, in the acute setting, if you have a patient that is acutely herniating, so they have Cushing's triad, they have pupillary changes, you're getting ready to take them down to head CT, you can take the patient off the ventilator and you can manage their CO2 by hyperventilating them. When you hyperventilate the patient, you are driving their CO2 down. And what that does to cerebral blood flow is it causes a decrease in it by vasoconstricting. So based on the Monroe-Kelly doctrine, where you have those three things that you can alter, if you're decreasing the amount of blood volume that's in the brain, you're giving a little bit more room for the brain to swell. Obviously, decreasing the blood flow to the brain is not good long term. And so after you see pupillary changes, and hopefully you've ordered your 3% hypertonic saline fluid bolus, and you are to the point where your fluid bolus is now effective, you want to maintain normal carbia, and you want to do this in a slow fashion and not have big swings. And then the other things to consider when you walk in the room, make sure that patient's head is midline and make sure that they're at 30 degrees. 30 degrees is a lot higher than you think it is, but that is certainly something that's going to facilitate and encourage drainage of the venous blood flow, and so it's going to decrease the amount of blood that's in the skull and allow for more swelling. Acutely, you also want to make sure the patient's not seizing. And so if they're seizing or you think that they're seizing, obviously a benzodiazepine. If you are unsure, you can always give them some Keppra, 20 milligrams per kilo, and make sure that they're on maintenance Keppra from there on out. In addition, you want to maintain their glucose in the normal glycemia range. And last but not least, if this patient has not had a decompressive craniotomy yet, you need to talk to neurosurge. So you're going to send this kid down for a stat head CT, and then you're going to talk to neurosurge and see if they're a candidate for getting a stat decompressive craniotomy. Because you need to open that box. You need to allow the brain to swell in this acute phase, because there is very little, once that process starts, that we can actually do to manage this. All right, so let's just kind of review everything that we've talked about. So we've talked about the Monroe-Kelly doctrine. Skull is a rigid structure with three components of brain, CSF, and blood, and if one structure increases, the others will be compressed. We talked about cerebral autoregulation and how in a normal patient, the range is typically from 50 to 160, and this can shift to the right during chronic hypertension. We discussed normal values for intracranial pressure of being between 7 and 20. We discussed the concept of cerebral perfusion pressure with mean arterial pressure minus ICP, and in patients greater than 18 having a goal of 50 to 70. But if you're in that young age range from 0 to 6, maybe it should only be greater than 40. And if you're between 6 to 18, maybe it just needs to be greater than 50. We also discussed the three types of edema, including cytotoxic, vasogenic, and interstitial. And then last, but most important, how to minimize the cerebral metabolic demand in the acute setting, and then kind of moving forward as you manage this patient. I hope that you have found that this lecture has been helpful. And there is a quiz that you can take through SurveyMonkey. If you click on this link, it'll take you to that quiz for a quick 3-question post-test. Thank you very much. And here are the references if you have any desire to read more about increased intracranial pressure and traumatic brain injury.